Good morning, students. I'm Dr. Zuhair Al-Johar. Today we'll have a lecture about intracranial infection. Well, the objectives of this lecture is to know about clinical presentation of meningitis and encephalitis, to know about common infective organisms responsible for meningitis and encephalitis, to know about the pathophysiology of them, and to know how to investigate those patients, how to make a differential diagnosis, and about the empirical and specific treatments of meningitis and encephalitis, and about the complications. So now we'll speak about CNS infections. I want you actually to think about it in this way. The main sites that we have the inflammation in are either the meninges, or the brain parenchyma, or the parameningia, or the parameningeal structures, whether they are the paranasal sinuses, or the mastoid, or the middle ear or inner ear, brain abscesses. All of those are called parameningeal. All right? Spinal epidural abscesses also in the spinal canal. So it's better to think about them in this way. Anatomically, I mean. Before we'll go here, I will go to other slides. I'll go to other slides, really. I'll move to other slide now. Let's take the cases and see how you can work with those. Okay, we'll start by this case. See, this is a 10-year-old boy. He presented with fever, headache, and photophobia, vomiting, and of 3 days duration. It was very toxic. He had a history of similar condition, and his brother was noted, and which led to death. And that was recent, really. On examination, he had neck stiffness, Koenig sign, and the CSF protein was 120 milligram per deciliter, which is high. Sugar 39, his blood sugar was 99, so it's less than 1/2 or 1/3. Actually, less than 1/2 and less than 2/3 of his CSF or of his blood count. So this is significant. So it's having low CSF sugar. Cells were 600 white BC. 90% of them are neutrophils, and you will see the ground stain on this picture. Let's see the ground stain. This is the ground stain. You see that this is gram-negative diplococci. You see it right, then it's gram-negative. See gram-negative diplococci here. Let me show it to you. These are the pointer pointing them. Gram-negative diplococci. Sorry for that. And here you see this rash, which is purpuric rash. It doesn't blanch by pressing it. So he developed this rash later on. So you see this purple crash. So all of this evidence we bring back with some of the picture again. So this is our case. So you see, he had fever, headache, and photophobia of the vomiting. 3 days duration, was very toxic. His brother had similar condition, which led to death of his brother. The same rash happened in his brother also. And he had positive signs of meningitis, meningeal irritation signs, neck stiffness and clinic sign. And he had also a CSF suggestive of bacterial meningitis because it's high in neutrophils. It's 90% neutrophils. So here we are having a clear clinical picture of meningitis with approved by CSF, and we have a purple rash and gram-negative diplococci. So this is a clear case of gonococcal meningitis, which is highly infectious. So this is another case where we have a 5-year-old boy presenting similar to the other one with fever, headache, vomiting. This triad, you should always think about it when you see it in patients. You should always suspect meningitis actually. 3 days duration also, so it's pretty much acute, although not very rapid, like what happens with subarachnoid hemorrhage. It is slower than subarachnoid hemorrhage, but it's pretty much acute. So you think of bacterial meningitis, so it's not subacute to think about TB or others. He had also neck stiffness, clinic sign, positive. CSF protein was similar, 120 milligram per deciliter, which is fairly high, more than around 45 or 50. Sugar was also below 1/2 or 2/3 of blood sugar, and his CSF and his cells were about 600. Also 90% neutrophils. So pretty much it's the same, exactly the same picture as the one before it. So let's see his gram stain. That was the picture, that was his gram stain. You see here, we are seeing gram negative also, they are red in color, so they are gram negative rods. Gram negative rods. So basically gram negative bacilli. And sometimes you see, like here, like cocci. So you have gram negative coccobacillus. So this is actually Haemophilus influenzae. So it's Haemophilus influenzae meningitis. Here you see in this picture, in this slide, 35-year-old man, non-thalassemic. So he has thalassemia. Also presented with fever, headache, and vomiting of 3 days duration, with also signs of meningeal irritation signs. His CSF protein was 200, which was pretty much very high. Sugar was low, white BC count was very high, and 90% of it was neutrophils. So this is the classical picture of bacterial meningitis. Low sugar, high white BC neutrophils, and high protein. So it's clinically and by CSF, it's proved to be meningitis. Because he has thalassemia, he had splenectomy before. So 1 year ago, he had splenectomy. So what would splenectomy made people prone to? Let's see the gram stain. This was his gram stain. This is gram positive this time, it's purple. And here you see the cocci. And you see them, they come in doublets. This is diplococci. Chains of double cocci, diplococci. That is gram-positive diplococci. So this is Diplococcus pneumonia or Pneumococcus pneumonia. So this is pneumococcal meningitis. You should always think of pneumococcal meningitis in elderly patients. Haemophilus influenzae, if you see the other case, in Haemophilus influenzae, we are actually having something like 5-year-old boy, because this is the typical age for, children, young age for Haemophilus influenzae. But when you are presented with a patient who is about adult patient, so you should think of actual pneumococcal meningitis more, because this is the most prevalent one, most prevalent kind of meningitis in old patients. In adults, in adults, and it's the most dangerous one, and the one with the most frequent complication, and even death rate. So it's the most severe one of the pyogenic meningitis. So now we take another case, a 30-year-old pregnant lady with fever, headache, and vomiting of 5 days duration. So we have here pregnancy into the picture. Pregnant. Now what she has, she had also an acute deterioration in the level of consciousness. So her level of, and she has double vision. So she has a focal neurological sign. So she has focal neurological sign, she has decreased level of consciousness, and she had pretty much the classical triad of meningitis, the fever, the headache, and vomiting. And the presentation is acute. She has also neck stiffness, Koenigsegg positive. She had bilateral abducens. She has spastic quadriparesis. And this localized lesions to the point. So she has a pontine involvement. So she have a focal neurological sign. She have signs of meningitis. The CSF protein is pretty much the same as the others. As we see 309% neutrophil with low sugar and high protein. So you have clear evidence of meningitis with pontine involvement, with brainstem involvement. Of course, in this case, you might suspect also that she might have encephalitis, because we will speak later about that subject. Because if you have deterioration level of consciousness or focal neurological sign, then actually you're having 2 of 3 symptoms of encephalitis. But this case was not encephalitis, actually. This case was a complicated case of meningitis that involves the brainstem. So let's see what is the CSF, what the CSF shows us that this is. So it's gram-positive bacilli and sometimes cocci. So gram-positive cocci, mainly bacillus, really, sometimes cocci. That is a case of Listeria monocytogenes. Listeria monocytogenes meningitis, which is known to cause a brainstem complication, especially in the bones. So this is a very dangerous kind of meningitis, and you see here it's associated sometimes with pregnancy. Actually, it's associated with any condition that can cause depressed immunity. So any condition, people on steroids, people on chemotherapy, sometimes malignancy, diabetes, elderly or very young, all of those are susceptible actually to Listeria monocytogenes. Listeria monocytogenes also, one of its characteristics is that it can be transmittable by food. So Listeria monocytogenes is one of the severe forms of meningitis because it resides or it affects people who have bad immunity. So tend to stay for a longer time. So you need to treat it for a longer time, like 3 weeks or something like that. Now we come to this case. That's a 17 years old girl. She brought to the A&E with severe agitation, speaking nonsense, sustained 3 fits, each preceded by abnormal sense of smell for a few seconds. So these are actually focal secondary generalizing seizures. So there is a focal seizure and there is a deterioration in level of consciousness. On examination, there was rather mild neck stiffness. Current exam was actually negative. However, she was delirious. It means that she was having delirium, which is agitated confusion. CSF showed a protein of 7 milligrams per deciliter, so it's high, but it's not very high. Not like what you used to see in the other slides. The sugar was naturally normal in CSF, and the cells were slightly high, like 10 MyPC, all being lymphocytes. So this is abnormal. Gram stain was negative, so gram stain was negative totally. And the EEG revealed bilateral temporal spikes, and MRI picture, you'll see it here. That's the picture of the MRI. You'll see this is the involved area. This is the involved area. It is hyper intense, and it's bilaterally in the mesial temporal lobe. So this is a T2 MRI image showing a bilateral inferomedial temporal lobe involvement. So this is the cause of the partial seizures. So it's temporal lobe epilepsy or secondary generalization, plus evidence of meningitis. And as you see here, this case differ a little bit from meningitis. You don't have the Koenig sign, you don't have the low sugar and the very high protein. The cells are not so high like what you see in the meningitis and the prior counts. They're high, but not very high. All of them being lymphocytes here. They are not like the previous one, which were neutrophils. So this shows that this case is different from the other. When you see all of them being lymphocytes, it's not that very high. So it means that it is usually not the bacterial form. So this case actually doesn't hardly have symptoms of meningitis or signs of meningitis. And they have also some marked involvement of consciousness, deterioration level of consciousness, and seizures with focal involvement. So you have all 3 pillars actually to get an encephalitis, which are seizures, focal neurological signs, and deterioration level of consciousness. And you have less involvement on the meningeal side, like the neck stiffness is not very marked. And of course, the CSF is towards viral, actually, origin rather than bacterial. So this is a viral encephalitis. Most causes of encephalitis are actually viral, while most causes of meningitis are bacterial. So, okay, now we saw several cases of bacterial meningitis and 1 case of encephalitis, actually. So we got familiarized a little bit with how those clinically present. Let's go a little bit back and summarize what we know now. So To summarize what we said, the clinical picture, we see usually headache, fever, and vomiting. So that we put it in this way: headache, fever, and vomiting. So this triad is the basic triad of meningitis. Plus any two, if you see any two of, plus photophobia, plus neck stiffness and Koenig sign. So fever, headache, vomiting, sometimes photophobia, plus neck stiffness and Koenig sign, Brzezinski sign is most probably meningitis. Sometimes if you see two of decreased consciousness, seizures, and focal neurological sign, then you will think here of the possibility of having encephalitis. So you see, this is encephalitis because we had fever, headache, vomiting, and photophobia. All right. So we have and neck stiffness and we have side of meningitis on top of those. So that's why they appear as encephalitis. While if you only have headache, fever, vomiting, possibly photophobia, plus neck stiffness, Koenig sign, and Brzezinski sign, then here this is meningitis. All right. So this is the picture of meningitis. If you have both headache, fever, vomiting, and neck stiffness, plus two of consciousness, seizure, focal neurological signs, then you are with encephalitis, or sometimes complicated meningitis, like how we saw with the case of Listeria monocytogenes. The pathophysiology of meningitis I pretty much showed you in the handouts. And so there are two slides speaking of that, of the pathophysiology of meningitis. But the point that you should know and concentrate upon is that it's the inflammatory response actually to the invading microorganism that is causing most of the damage. So you see, inflammation with issue, we will have fibrinous exudate, which will turn into fibrosis. These fibrosis might close the ostia or the passages of the CSF passages, like phenomena of that controls CSF passages, which lead to hydrocephalus. Also, you can have subpial encephalopathy. All of those can increase the cranial pressure. You can have brain edema, which lead to herniation. If the infection or inflammation goes to the vessels, you will have vasculitis, and this can cause infarctions. And you can have also venous sinus thrombosis and all of these things. So most of these are due to the inflammatory burden actually. It's due to the response of the body to the microorganism. Of course, the microorganism itself can cause direct damage. But much of the damage is not only due to the microorganism, it's due to the inflammatory response that the body mounts against that microorganism. So this is a very important and vital aspect of meningitis, because you should always take that into consideration during treatment. When you treat patients with meningitis, the aim of the treatment is not just to kill the microorganism, it's also to curb the excessive inflammatory response in order for it not to cause any damage to the patient. You can see these slides, they are present in the handout, and also this slide about viral encephalitis and bacterial meningitis. Also, there are various slides showing ventriculitis, subcortical infarct, and this inflammation of the vessel, which is usually perivascular, it begins. This is the supine encephalopathy, there's inflammation of the cranials. So you see, it's the inflammation, all of these neutrophils, inflammatory cells there with the complement and all of that, causing cell destruction and causing a lot of the damage around the nerves or in the cortices or even the ventricles. And here in the subpial matter also Uh, it surrounds the nerve. As the nerve pierce the perimeter, they can the infection can go to the nerve and to the arteries also. So pretty now let's speak about the etiology. We have two kinds of meningitis, broadly speaking, can be infective and can be non-infective. Those that are infective, infection can be by any pathogen actually. It can be bacterial, like pneumococcal, meningococcal, haemophilus influenza, and listeria monocytogenes, the one that we saw, or it can be subacute. This will be the basis for our next lecture, which can be TB meningitis or brucellosis or fungal. Sorry, if it's bacterial, TB meningitis, or rickettsial or brucellosis. Viral, like many viruses can cause meningitis actually. The main ones are herpes simplex, but still varicella zoster, Epstein-Barr, John Cunningham virus, other actually can cause, especially those viruses of hemorrhagic fever and all the others. Fungal also can cause meningitis, especially in immune-compromised patients. And there's a non-infective causes, which can be malignancy, whether it's infective malignancy or hematological, or can be radiation, like radiation meningitis or chemical meningitis, like what happens with subarachnoid hemorrhage or introducing some chemical in the CSF. So you need to know etiology according to age. This is present in Davidson. So you can see the different pathogens and their distribution throughout age. In particular, see here that Haemophilus influenza is in preschool children, while the adults with streptococcal pneumonia or even Neisseria meningitis. While at the very young, you see gram-negative and will be streptococci. So now what we are going to do, if we are presented with a patient that has the signs and symptoms of meningitis, I mean, what's the management? We pretty much now, with the aid of the handouts also, I want you to see them very well. We will have a good picture about what is the pathophysiology of meningitis, and we also spoke about the clinical picture. Let's see what is the CSF actually analysis can provide us, and then speak about management. Let's go here. So slides. Yeah, let's see the CSF changes. The parameters of CSF will have actually manometry first to measure CSF pressure, then ground stain, then we go to serological test, can use procalcitonin, PCR as the last test. So these are the main ones which we look for. So CSF analysis here actually. Let's take this CSF changes. Let's take here first the appearance of the CSF. Here what we are seeing is the cobweb appearance, which is typically associated with TB meningitis. This can appear about 2 days, within 2 days of taking the CSF. So it's prudent actually to keep and store some CSF of a patient whom you suspect that he's having TB meningitis in order to see that sign. Because TB meningitis is difficult to diagnose and is often missed. So this might herald the idea that he's having TB actually. Here, the CSF appearance is that of a cloudy appearance, which is typical of like bacterial meningitis and septic meningitis in general. It means that there is a lot of white feces there and inflammation, you know. while in aseptic meningitis will be clear, like with viral meningitis sometimes, and your non-infective causes if it doesn't have very high white BCs, or sometimes even very high protein can cause this picture. So this is pretty much about the color of the CSF. So in CSF analysis, we take the appearance, as we saw, turbid and turbid or the cloudy that we just saw it, or the opaque cobweb formation, or the clear one. And you should know the pressure, which is usually can be high with bacterial meningitis actually. And then you take the white BC count, protein count, the glucose. Chloride is not that very important like these three. And from them, you can know whether it's tuberculous meningitis. For example, in particular tuberculous meningitis, you might see a mixed lymphocytes, neutrophil count, like 60% lymphocytes, 40% neutrophil, So you see, glucose might be decreased or normal in tuberculous meningitis. Protein can be as low as 50, but it can be very high, especially if there is spinal block, because very high protein. And also the pressure is also very important here. So we pretty much spoke about that in the prior. And these are the CSF parameters in general. So now what we are going to do, what's the workup for a patient who's coming with meningitis? Of course, definitely anyone who will come with meningitis, you will do the ABC for him, and you will take a history, medical history and physical examination. And then after that, you will order generally these investigations. Complete blood picture, ASR, urea electrolyte liver function test, take a nasopharyngeal swab, nasopharyngeal swab, not oral pharyngeal swab, nasopharyngeal swab, and blood culture. You do that actually immediately in any patient who presents to you with a clinical picture of meningitis. So you do it immediately, especially in the nasopharyngeal swab, if you can do it, and the blood culture. You do that actually immediately. The main question is to do a CSF or not. That's actually the main question in meningitis. So if there is no contraindication, you do CSF. But at the beginning, you are going to do these basic investigations. And the point is that you should hurry in giving antibiotics. You should do it as soon as possible, because time means neurons. So loss of time, if you lose time, you lose neurons. So once you take the nasopharyngeal swab and the blood culture, you immediately give him the antibiotics. And then after that, you will see if there is a contraindication to doing CSF. Now, contraindication for doing CSF are mainly the presence of a mass lesion in the brain that is significantly compressive. So like there are signs of midline shifts or that have a very big impact. It's not a small focal neurological lesion. No, it's a big focal neurological lesion that is causing displacement, brain displacement. So those are the danger, because if you do CSF in those patients, you can have herniation. The other contraindication actually is if you have very high increased cranial pressure. So a patient actually with florid papilledema, like grade 4 papilledema or something like that, you should be cautious in doing CSF about him. But generally, the consensus, as if he doesn't have any focal neurological, mass lesion, with then you won't do it. But if he has a mass lesion and he has papilledema, then definitely you won't do CSF for him. So CSF should be done as soon as possible and sent for bacteriological gram stain examination and culture and the other tests that we've just spoke about. Of course, you will do a chest X-ray, sometimes even paranasal sinus X-ray, and CT scan and MRI brain for sinuses and other parameningeal foci if you suspect them. These would be very important, the CT scan and MRI brain, if you have evidence of focal neurological lesion or papilledema. But in case the patient doesn't have any focal neurological lesion, doesn't have papilledema, and he only came with symptoms of meningitis, then in this case, you will do CSF straightforwardly. You don't need to wait for a CT scan or a brain MRI to do that. You shouldn't delay the CSF. You should do it as soon as possible. Sometimes we do EEG, like in cases with encephalitis. Magnetic resonance venography and MRI are important because many times, actually, cases of cerebral venous thrombosis can mimic actually meningoencephalitis. They can mimic them very, although they are usually come on a more rapid tempo than inflammatory disorders, but sometimes they are indistinguishable from them. So you need to do MRV also in the follow-up of the patient. You need to do a magnetic resonance venogram to exclude actually having extension of the inflammation to the venous sinuses. Sometimes you need to do tuberculin tests in those we are suspecting of having tuberculous meningitis, HIV screen in some patients. But the main point is to do an nasopharyngeal swab and blood cultures as soon as possible. Give the empirical treatment. We'll speak about that in the next lecture, and to do CSF as soon as possible. Sometimes you might need to do for the CSF if there is a significant increase in cranial pressure or significant focal neurological lesion that you need to do an MRI to exclude that there is a mass lesion. But if there is no mass lesion, then you can proceed and do CSF. If there is a very florid papilledema, then you'll do what is called safe CSF. I mean, if he has a very significant papilledema, but he doesn't have any mass lesion at all, and no specifying lesion, still you should be cautious when you do the CSF. So you do it with a needle with a very small gauge. You only withdraw a very small amount of CSF from it. So this is pretty much the flow chart of the management. So resuscitate the patient. This is first. Give him empirical therapy. If he's drowsy or having focal neurological signs that you are suspecting mild lesion or hydrocephalus or cerebral edema, that's what we spoke about, then you will send him for CT scan. If he doesn't have those, there is no no other contraindication to lumbar puncture, like having low platelets or liable to have hemorrhage or having significant infection over the area of the lumbosacral area, all of course, like a significant lesion there that you cannot do lumbar puncture. If you don't have these, then you do lumbar puncture. If you have this focal neurological sign, you do CT or MRI and you see it, and there is no mass lesion or hydrocephalus or significant brain edema, then you do LP, of course. Now, the mainstay of management of bacterial meningitis and viral meningitis, of course, the antimicrobials. There are two kinds of treatment, really. There are the empirical treatment and there are the specific treatment. Now, the empirical treatment, we mean the initial treatment that you will give to any patient who is suspecting of meningitis. And you have strong clinical and biochemical evidence for it, like a positive CSF and strongly suggestive clinical picture. In this case, you will start the empirical therapy straightforward after you do the nasopharyngeal swab and the blood cultures. So this will be directed to killing all possible suspected microorganisms in your setting, I mean in your country and in the setting of the patient. So in this way, you will give usually antimicrobial directed against the most common bacterial microorganisms, I mean, and the viral. So it'll give you a high dose cephalosporin, meningitic dosage, actually, there are very high dosages. Vancomycin to cover bacterial resistant form, pneumococci, I mean, resistant to cephalosporins, and you will also, in patients who are immunocompromised, you will give ampicillin for Listeria to cover Listeria monocytogenes. But if they are not immunocompromised, so you will be content with giving cephalosporin and vancomycin, and coupled with it, you will give also antiviral therapy, because viral meningitis and encephalitis, viral meningitis or meningoencephalitis and bacterial are most of the time actually indistinguishable. So you will give also with it acyclovir, all right, acyclovir in meningitic dosages, which is 10 milligram per kg per dose IV over like 60 to 90 minutes, 3 times daily. So you will give, so we end up most of the time giving high dosages of cephalosporin, vancomycin, and acyclovir. And if you have a high suspicion of TB, then you will give antituberculous as well. Then after that, when the results will come from your CSF culture and direct exam, specific results that tell you which microorganism is there, then you will change to the specific antimicrobial therapy. So now to go back, as we said before, it's not only, the aim of the therapy is not only to kill the microorganism. One of the main aims of therapy is to curb the excessive inflammatory response that the body mounts against these microorganisms. So here for pyogenic meningitis, you'll give dexamethasone, 4 milligram, Q6 hourly, it means every 6 hourly. It means 4 times daily for 4 days. 4 milligram, 4 times daily for 4 days. For herpes simplex encephalitis, the role of steroids is not that established as it is for bacterial meningitis. So I'll give about 8 milligram every 12 hours for around also 4 days. In TB meningitis now is different. In TB meningitis, as we will see in the next lecture, we need steroids for a more prolonged period of time, like 20 days or sometimes even more, according to the clinical picture and the response. So steroids are very important. So the mainstay of treatment of bacterial meningitis or encephalitis, all CNS infections, is actually antimicrobial therapy with steroids at the beginning. Now, this is the specific now here, antimicrobial therapy. This is the specific one. This is only launched after we know exactly the cause of the meningitis or the encephalitis. Now, what is the prophylaxis, especially against meningococcal meningitis? Those prophylaxis are especially given to households, especially children, and to people who accompany the patient with meningitis. Like how we have in our hospitals, we have a companion of the patient, so we should have also that, and some of them to the medical staff taking care of him. So a single dose of ciprofloxacin is recommended. Also, another regimen is to give rifampicin twice daily for 2 days. And the rifampicin dosages, if it's a child, it's less than 1 year, it's 5 milligram per kg per dose. And if it's more than 1 year, then it's 10 milligram per kg per dose. And in adults, it's 600 milligram per dose. Complications of meningitis. Now, the inflammatory response mounting against the microorganism might cause fibrosis at the CSF passages. And so this can cause hydrocephalus. But usually usually appears after 2 weeks. But sometimes if the inflammatory response is very severe, even the fibrinous exudate can cause early hydrocephalus, which is most of the time responsive to clinical treatment. But if fibrosis occurs and it's the cause, then it won't be responsive. That will need surgery. Cranial nerve palsies, stroke, dementia if it destroys most of the cortex, amnesia, aphasia, renal sinus thrombosis, and death. So now this concludes, our lecture and most of what I wanted to. So I want you to see the handouts. The handouts have a presentation of the various pathologies and also of meningitis, a small video about meningitis, and the sources actually, you see, I want you to see the sources. These sources are extensive. They are for further study, actually. You need also to read Davidson's, just in case a lot of things you couldn't understand here. And I am happy to receive any questions. All of your questions, you should direct to the discussion group, my discussion group, and I'm happy to answer all of them. So don't hesitate in sending any question. Actually, this is an activity that is demanded from you, and then you will be evaluated on raising questions on our lectures and discussing them in the discussion group present in the INLA. Thank you.